should be good.
Hello, everyone, and welcome to another episode of the GeoAI podcast. I get the pleasure of being your host. My name is Ajay Gupta. I'm joined today by a number of wonderful individuals. I will introduce them all one at a time, but some that you all recognize are Paul Churchyard, who essentially produces the show and handles everything behind the curtain that we ask you never to look behind, and also Ram Paravemba, who is my partner in crime and business. An anesthesiologist and as well as a hospital-based pain management physician. So we're certainly going to talk about a lot of things that he knows a lot about. And I am joined by a number of other wonderful people who will help us all today tackle clinician burnout. We'll talk about the numbers, the issues, the cases, and we'll also look at how we can possibly make a dent in the problem. Let me run through our guests. I'll introduce them one at a time, and they'll I'm sure, have a lot of wisdom to bring. First, and in no particular order, is Jody Green, CEO and president of the Clinician Burnout Foundation, who is essentially finding innovative ways to fund efforts at the grassroots to stop clinical burnout. She's going to tell us exactly how that works. And Dr. Dana Dixon, a human-centered leader and a frontline nurse leader who's got a lot of experience about what the problems are and why we haven't really been able to solve them over the years. Next up is Tanya Abreu. I hope I'm saying that right. It's a beautiful French name. Visionary healthcare leader and the founder of an organization called Power Up Nursing that has put together a dream team of technologies and personalities to attack the nurse burnout and the nursing workforce issues. Joining her from Power Up Nursing is their Vice President of Education, Transformation, and Optimization, Dr. Kim Delbo. I am delighted to have all of you join us. Welcome to the show. Welcome to the podcast. And let's jump right in today because this is a busy podcast. It's a busy issue, and it's one that is of substantial importance because in all of the conversations we have about healthcare, about the need for improving care capacity, the need for seeing more patients, treating more patients, making more healthcare access, or improving the availability of healthcare by increasing access, and by also inventing new diagnosis, treatments, and clinical interventions, we sometimes forget that we can't actually deliver any of these new solutions unless we have a skilled and vibrant clinical workforce. But when we look at the workforce we do have, all too often, all across the country, and really to an extent around the world, we don't have a sound, solid clinical workforce. So let me turn to you, Jody, to ask sort of the first question to get us off. What do you think the problem is? What, from your vantage point, do you see as the problem and why we don't have necessarily a vibrant clinical workforce? Well, and again, Jody, welcome to the show.
Oh, thank you for having me. I'm thrilled to be here, and definitely everyone here is an esteemed colleague, and it's lovely to meet everyone. This is, I'm a non-clinician. It's very personal for me, just an attitude of gratitude over many years as a longtime caregiver for an autistic brother, and my mother passed away recently, but she had problems as well. And so I've always wanted to support everyone in the workforce. I don't want to go back to leeches. I'm a little afraid we're going in that direction, like to help us not get there. So, it's been a profound problem, right? And studies on physician burnout foremost have been consistent since the year 2000, been hundreds of them. And really nurse burnout has been overlooked until very recently, which is this is the largest workforce in the US, well over 5 million. It's the largest workforce globally. And so that to me is really unconscionable, but starting now, and look, this is one of these times it is being brought to the forefront and hoping to get that out there more. But there's so many things. I mean, burnout, it's been regulatory, tsunami of regulatory, lower pay, greater responsibility, and burnout and moral injury is a big thing as well. Those the healthcare really, it's a calling, and yet it's not something that, it's when you're treated like a widget or an automaton. And I've actually seen headlines not very recently. I don't doubt other people here have seen it too, where it's like AI is going to replace nurses. I just was like, okay, let's get those people out of business, whoever that is. I don't know. But,
part of the problem there, though, Jody, is that we are not able to fill the bedside need for clinical care with nurses. And there are many hospitals around the country, and not even recently, not even in 2025, but years ago, 5, 6, 7 years ago, that have closed wards or closed hospitals because they don't have enough nurses to treat patients, right? So the AI, obviously, it's a reflection of the advanced technology, and people want to sell technology. There's no doubt about that. But another part of it is that if we don't have, or we don't have a reliable, affordable workforce in place.
I didn't finish the thought on that. So I'm actually an investor and been part of an AI health company. Obviously, sorry to cut you off, but I know what you're about, which is why I love what you're doing. No, AI, let's get the EHR working better, get rid of the 80% error codes, the Apple-like interface, NASA-like algorithms, make it accurate and simple to use. Let's cut down. Nurses should not be data entry clerks. So I think AI there and can speed up potential diagnoses. I have no problem with that. It's saying, we'll have a robot. I mean, nurses.
Well, Jody, it doesn't help. It doesn't help that they have a sexy all silver robot that's called Nurse Roxy or Sharon, and that's what they're promoting, right?
Right, but
tell us a little bit more about that, Tanya. There's a sexy robot nurse that is being promoted currently.
Yes, you guys keep talking. I'll find her.
Yeah, there's also, nurses are the only real cradle to grave, literally at the moment of birth, and the ones at home hospice I had with my mom who were there holding the hand. And
that's true.
So not only the largest workforce, but the largest that is high touch. They touch us. I very much believe low touch and technology. Like I'm very much involved in that, right? Very much involved in health tech. There's just a place for it, right? And it's not one or the other. It should never be a binary choice. We should never bifurcate this. We should find ways to make it work, to synergize so exponentially greater. But the other thing I really want to stress is violence in the workplace. Nurses are now being considered to have, studies vary, but right now I've seen more often than not, nurses have the number one most violent job in America. Members of the military, law enforcement do elect to face danger. Nurses do not. And until
they elect to save us from danger. Yeah, that's true. So let me turn to Dr. Dixon and Dr. Delbo now. Both clinical nurses, both have had bedside experience.
Sorry,
talk about what that's about. What maybe across your careers, across everything you've heard, where did this come from that we as patients and patient family members feel that it's okay to be violent towards the people who are literally trying to help us? How'd that happen?
Two things come to mind, and Dana, I'll let you go first if you have something.
Please.
Okay, so two things come to mind. Number one, it's the perception of nurses in our society, right? How are we looking at nurses? And over the decades, we have not looked at nurses through the lens of adding value to our society, right? We've been a line item in a budget, right? In many senses. Additionally, I think about culture, but I also think about how nurses are closest to the patients, right? We just said we're the largest number in our healthcare workforce, and we are also the most trusted for 23 years, right? So are we living in a society that takes advantage of the most trusted? I ask the question because I'm a spirit of inquiry, right? That's where I come from. We're additionally living with the fact that our society is seeing a mental health crisis. We didn't see this and experience this until most recently, right? And burnout is in that category of this mental health crisis, a social isolation and loneliness epidemic that we are experiencing. Again, these are all societal issues. So in order to address these issues, we have to look at it from a systemic perspective, right? And a systemic
Okay.
lens. So that's my thoughts.
That's an interesting point. So you got to look at it from a systemic perspective in terms of the problem as a whole. So this is going to be a tough question. Tanya or Dana, jump in as you think you can. But when we are doing clinical wellness, that is something chief nursing officers, chief financial officers, administrative leaders in hospitals need to address. So what kinds of things do resonate with them relative to the burnout or the status of their clinical teams, do you think?
So I'm going to jump in and say, I don't think that we're still connecting well, honestly. The idea that there's a relationship between burnout and its downstream impacts or upstream impacts, however you choose to look at it, right? Mm-hmm. And so as I was listening to Kim, this idea from a cultural perspective that's embedded since nursing school, that as a nurse, you're going to hold space for the patient, regardless, without judgment, and that is true, right? We're non-judging from an ethical perspective. We care for everyone. And people have confused that capacity with acceptance and tolerance for everything and not enough focus on protecting us. I think when you start to look at from a metric-based perspective, a workplace violence incident now laying your nurse out and up. So you talk about the injury to the nurse's psyche, but let's pause there and look at it from a bottom line perspective. That's now a nurse that you have to fill, whether you're going to have to get an agency nurse. That's a nurse who's now impacting morale, because who really wants to go into that room and care for that patient if the correct things weren't put in place in the first place, right? So when you talk about the correct things being put in place, it was an assessment done that this might be a violent patient and therefore have the appropriate resources applied. Did we decide that those resources were appropriate and how, right? So it's sort of like, well, the patient's a little combative, but you can manage it. The patient's a little bit combative, but you can manage it. Can I? Can you? Can Tanya? Can Kim? And so are we encouraging those conversations with our healthcare teams? Because there is a cost associated for not managing it well. And so that's a finance piece. And then there's a human piece, right? There are people here. And I think Jody talked about moral injury, and that comes up when you're sent in to care for someone and you weren't taught to do that well. You weren't protected or insulated enough. You sit there and you go, should I have understood that I needed to duck? Should I have understood that that was a point where I shouldn't try any harder? I should actually remove myself from that space. And where did that training or where would that information come from? That's not something, when we look at our nursing schools or programs, we're focused on getting people to go give and deliver safe care. I think it's recently that we're understanding, and to Kim's point earlier, with the growing mental health crisis, that we need to actively layer in other pieces and parts of support. Does a nurse understand when she's fatigued, don't pick up that third shift? Don't answer that phone call for overtime, or answer it and set that boundary limit to say, I would love to, but I can't, or I can only come in for half a shift because that's what I have to give safely. And I think that's where we need to shift it, because I think you go in for that shift and then you end up out,
you're not at your best.
Weeks,
yeah.
Right? That's a real problem.
And I'd like to jump in there only
Please,
because
Tanya.
I've been a part of C-suites myself, and of course, for the past 30 years, have used all my time helping them. But the real issue is nurse well-being, in my opinion, until now, has not been measurable. And if we're looking, and right now at a hospital, if I want to put our Power Up nursing program into place, I have to talk to the CFO or the board of directors. The CNO is not the person of power right now. And that's a scary thought, but that's my reality, because what we need to do is raise that preeminence of nursing. But let me go back to what we need to talk to healthcare C-suites about. I learned this from you, Ajay, that top 54 corporations in the world spend a significant amount of their profits on staff well-being. And that seems to be a direct correlation to productivity in industries like airline industries, tech, tech. Bezos built an empire on employee well-being. So did Jobs. But care seem to think that it's patient well-being that drives our business. And until we can, And so what I find CFOs excited about, Jody, I'm sorry, is that yes, Grace is the one that the nurse that's kind of nice looking. And then there's another nurse called Neurobot. And the CFO will say, oh, let me get those because they won't be attacked. They won't complain. They won't get sick. But it is a total misunderstanding of nursing as the productivity energy in a hospital.
Right.
And so like this, Ajay, I know you know because you can measure it. You just mentioned exhaustion. At Jackson, a nurse can say, look, my score has been under 50. I do not have a recovery score that allows me to make decisions in the ICU. What does a CFO do with that?
Okay. So I want to come back to you in a moment, Tanya, and have you tell us the whole Power Up Nursing program, because I think that is innovative and multifaceted. And it might be something, Jody, that I'd love to get your thoughts on it after Tanya says what it is in detail on how you might you get that from an investor perspective. But I want to turn to Ram a little bit because we've been talking about, and Dana mentioned an interesting point, that a nurse might be in a certain state, whether it's exhaustion or burnout, or as Tanya mentioned, there's a particular score through what she'll talk about in a second in her wellness program that does not allow a nurse to do her best or his best. That is something both chief nursing officers, chief clinical officers, and CFOs will understand. So how would, from your perspective, how would management, hospital leadership incorporate that kind of information in their decision making on a day-to-day basis with respect to patient care?
Thanks guys for having me here as well. We have obviously have physician burnout just as much, at least I believe, as nursing burnout. And it may be more specific in certain fields like emergency room and basically hospital physicians, I think, who are confronted with a lot of the same issues as nurses who work in these large hospital facilities. It was interesting what Dana was talking about as data points in terms of like violence and so forth. I mean, she kind of brought that to life. I mean, I know that exists. It's verbal, it's physical, it does happen. We even have situations where we call codes for those things. I think it's code green. In most hospitals is like someone who's causing physical violence and so forth, or imminently. So this happened. And by the way, that happens a lot. Every single week, there's those events. I don't know exactly what happens at those things. I don't go to them. It doesn't require my expertise. Probably I walk the opposite way, but that's but it happens every single week. So that's an interesting data point. I mean, overall, I think there's so much data, and this is kind of the area that I've been that I think we've been emphasizing, is there's so much information, whether it be from the nurses or maybe from physicians and other people who work in the hospital. But in addition, we have data that's being collected in terms of these incidents, what happened. For example, we use AI like more and more these days, like trying to predict specific like clinical things that might happen or that are imminent in the next few minutes. For example, an ICU may use AI to look at EKG rhythms that are occurring over the 10 minutes prior to a cardiac arrest or something. But here we have data points that we may be able to use to try to predict that violence, to try to do things that might prevent that from occurring within those last 2 or 3 actions that might be occurring for a specific patient and so forth. So these are kind of things that we really need to look into. You know, I'm sure nursing burnout, physician burnout, some of the similar things, too much work, too many hours, too many patients. But I think there are some unique attributes as well, as for the most part, for mostly that I can recollect, there hasn't really been a physical altercation between myself and a patient. There can be some verbal things, but they're often exposed to a lot more for the reasons that they stated already. So I think they're absolutely correct. There's been an assumption that they'll tolerate whatever, and that's been growing over the years, and that results in more altercations. The behavior often changes when I go in, so and it's often it's pretty obvious. But I think that's what I would say, is that there's a lot of information we can gather, and then in terms of the exact interventions, I think Dana and Kim and Jody have all posed some very specific interventions that can, from predicting bad altercations that may occur in the near future to providing them with wellness resources to try to prevent the burnout in the first place.
Predicting altercations that may occur in the real future, similar to the ability to, or at least the attempt to predict a patient who's going to make an adverse turn by monitoring all of their vital statistics. That's an interesting thought. And Jody, you have a follow-up question?
Or no, I wanted to add it on. What you're doing with HSR.health, the AI for predictive disasters, natural disasters, if you will, I think that it exactly applies here. And I know that others here have touched on it. It is society, those social determinants of health, and beyond that. We closed down mental health facilities years ago. We have more people on the streets with mental illnesses, not a criticism for the unhoused, that's just what it is. And it happens all the time, more people being forced into poverty. And so mental illness is unchecked, becomes like prisons, house people with mental illness. But they're out there. So it's really, I think, a way with AI and looking at the data is where the areas, perhaps urban hospitals or whatever. But when we see violence, it's not between doctors and nurses. It's people coming into the ER that are literally assaulting them. There are reports all the time about shootings in hospitals, and it's because they, what do? There's a sign on the main door of the hospital: no guns or weapons permitted, maybe a metal detector. It's like if you're a rampaging visitor or a really raving patient, unless, when there were mental health hospitals, there were things in place because those were often the patients who come in, and they haven't been applied now. And I think it's because, again, it's a devaluation perhaps of the position, or a taking for granted, and the moral injury and so forth. But we're talking literal violence. I'm not talking about verbal or bullying at all. And I don't want to make this all about that, but I think this is a key place for AI.
I think a lot stems from that violence, right? Yeah. Because it shadows and colors everything else, all of the other experiences nurses can have.
Well, and it creates the churn, right? The churn, and
so
that cost.
We've heard, Tanya, that AI may very well play a role. Can you tell us a little bit about the Power Up Nursing program?
I can. I'll try to be as briefly as possible about the platform. When we engage with a hospital, we work on an assessment, and that assessment includes the C-suite, in particular the CFO, to really get their perspective on nurses' damaging revenues. Okay, so what does that mean? They're not being retained. They're turning over. They're calling out indiscriminately. I'm playing the devil's advocate here. They're jumping. They're working 2-3 jobs and not giving us their best. And by the way, we can't, they keep going back to school and making, getting degrees, and we can't afford that anymore. I mean, the stuff that comes out in that conversation is mind-blowing. So we have that conversation. And then, of course, we have conversations with the medical officer as well as the nursing. And their concerns are, we're exhausted, we're making mistakes. Medical errors, they don't say cost money, they're costing lives. The concerns are genuinely clinical. So what we have done over the course of, this was incubated in COVID, or intubated in COVID, whichever way we want to look at it. But what we came out is this platform. And at the heart of it is that assessment, so that we can set goals that somebody like Ajay or others can measure with data, but we set those goals. The second thing we do is we create an app that belongs to the hospital, that's not on the hospital's IT system, so that everyone trusts it more. I hate to say it this way. That app is one app that all the well-being activities for nurses are centered in. So that means we're not going in there and prescribing new programs. What we're doing is showing the power of getting all of that in one place, so that we can track utilization and so that we can really see what's working. But we do bring something extremely immensely important to the table, and that is a wearable. In our case, we have a good pricing with Ultrahuman, but a wearable technology that measures HRV, heart rate, sleep quality, oxygenation, all of the things that let us know we're dealing well with stress. All of the things that let us know, including, I mean, you can monitor your glucose if you have metabolic issues as a nurse. All the things that impact our hormones are monitored. Those things that make us the very best person to show up at work. On top of that, however, as that data comes through unidentified to the leadership of the hospital, so they're able to see how exhausted physically nurses are, we also offer a mentorship platform, absolutely as a part of things. So, for instance, at HCAHPS.health, our pilot, they have decided they're hiring 100 new nurses a month and losing like 40. So what they've decided to do is not only put rings on these new nurses, but give them a mentor. And let's see what we can do within 6 months of that kind of intense partnership. The other thing that we do that's really, really important is that we offer ongoing program and communication to everyone that has that app. And then I think what's mostly exciting here, predictive AI, we already know how it works, but generative AI is included in that app, so that nurses have their clinical confidence. I don't care if a nurse is 30 years veteran or 3 months, to be able to go to your hospital policies and procedures, as well as 120 nursing and scientific journals, and ask a question in a bot. And all of a sudden, within a minute, you've got all of the options to really think about. It's not replacing you. It is truly augmenting you. And so then we look at 3 months and we say, what's changed? And it's phenomenal. Even if it's only a sense of nurse well-being and lesser call-outs, you're saving millions. And our program doesn't even cost $100,000. So it is really, really, really exciting.
Yeah, you mentioned the 40 nurse turnover per month at Jackson, right? I'm sure they're aware, and you're aware, that a single nurse turnover can cost hospitals as much as $60,000. The average cost of nursing turnover per nurse in America is just under $60,000.
It's crazy.
So for Jackson, that's like $2.4 million a month.
$1 million, right?
Which, given the margins in healthcare, Jackson's large, but even for them, that's got to be a painful data point that I'm sure the CFO is quite well aware of. So you've heard the program, Jody. I would like to just hear your thoughts, since you're and tell us a little bit about what Clinician Burnout Foundation does, and that you raise funds to support nursing wellness programs at the grassroots level.
Yeah, things like Power Up Nursing, in fact. So, and just to kind of tease out the thoughts of what you were saying. When you can turn burnout into budget, that's all. You're right. The decision makers are those with the power of the budget, right? So it's the CFO and the COO and/or CEO. I know COO roles are being phased out at this point, but it's not the chief wellness officers who's just fancy title and they're all burned out in 2 seconds. They have no authority. But to your point, though, it's unless you can translate burnout to budget losses, right? That's the metric. And it's not just, what does it cost to replace a nurse? It's, there are statistics that depending on the size of the hospital and the frequency and whether you have to shut down, you can't even do elective surgeries, right? Those costs then could be almost $160,000 per day. So until you show them that, and lawsuits, let's face it, patient, right? And patient satisfaction scores, when they're down, their reimbursements are lowered. I'm throwing out a few things that you guys know, but you have to talk to your audience the way you understand, right? So you're losing this much, not because they don't feel well, right? Or they're emotionally or physically tired. I just wanted to finish that thought for those who may be, watching this and hearing it. Perhaps some CFOs, I hope, from hospitals, other administrative positions, but it's right. It's a dollar cost, cost in lives and
Right.
and cost and cost in sustainability as we see more hospitals closing and more are owned by, health equity investment companies, and they really are about dollars and cents. So show them what they understand, which
It is about dollars and cents. You're right about that, Jody. I think we all recognize that, but we do care about the patient success and patient outcomes, right? And in large part because that's the purpose of healthcare, but also because those statistics, those measures are how we are compensated, right? So hospitals do get fines and penalties if they have adverse events, falls, hospital-acquired infections, readmissions, and they do make more money if they have a positive environment where patient satisfaction scores are higher. So we've been talking about turnover and reducing, and improving wellness for nurses as a way to improve finances because of less call-outs. But Dana, Kim, if nurses are in a better place to provide care, we would also expect, even within one quarter, that care quality would go up, and that's gotta be something that CNOs and chief financial officers will like, right? So, why is that connection between wellness and quality of care not been made, and how can we make that clear for hospital administration?
Ajay, I want to say, Kim, if it's okay for me to jump in, because you say quality and all parts of me just lights up. The boots on the ground are making the connection. The challenge has been in the measurement. And so when you look at things like staff fatigue, and we talk about near misses, and if you were to calculate what you saved when you catch it, then you talk about the near misses and the things that are unreported. There's a whole way that already exists to capture data points there.
Right.
The staff fatigue part, and when we look at like outcome data, and we do like a one level unit like based analysis on a root cause for an event that happened, within that unique scenario, you'll find, okay, the person was tired and that was contributory, but there's no way really within hospitals that we've been structured in reporting that or taking care of that. And so for me, I've had these conversations with nurse leaders like myself at the table, cafeteria, at the conferences, where we're like, if only there was a way. And I think the boldest for me right now is it's 2025. I'm a proud elder millennial. It's been 14 years of leadership, 20 years as a nurse. And when I get to, was it knowledge deficit or was it fatigue and was it both? Let's start measuring it and let's jump in with solutions. When the nurse, and when Tanya mentioned that the nurse doesn't have to go through a 40-page policy to get an answer on something, that's where we need to get to. I need to understand, is this the correct technique for Foley care? Because I have not had to do Foley care and I just got floated to this unit. That's the real sort of like meat of the matter. It's the understanding that I'm exhausted and I shouldn't pick up that shift. And I can get that information because I looked at that my brain data when I got that phone call from somebody. So for me, it's that near miss is a signal. It's a signal of something. Is it wellness? Is it fatigue? Is it knowledge deficit? We can work it out. We have the ability to now look at that and do that. And the other thing I wanted to talk about when we talk about the other metrics of measurement, such as like our experience data that comes in from whoever your vendor is, but that's highly nursing communication driven. I can tell you, and my daughter will tell you, when mommy is tired, and now I can understand when I'm tired or when my blood glucose is running a little low, that I'm not going to give as expansive of a conversation or explanation for something. So when a patient asks me, what's going on? Yes, Dana, the professional, has had 14 years in leadership. If I'm responding to the unit, I'm at the second level. Of course, you're going to get the picture perfect response. But when you look at that at the more base level, if I were doing that day over day and I wasn't the second level of response, am I going to be as expansive with that patient and saying, sit tight. I want to give you a more detailed answer. Let me go do this and come back. Or are you going to say, that's just not here yet? Your labs aren't here. No answer is wrong, but one answer yields a better communication relationship than the other. And you know the difference when you're tired, but are you aware of how tired you are? Are you gaslighting yourself into saying, I'm okay, I should just power through it. It's only my second shift. Like, yeah, but what did you do on the day off that you were cleaning your whole house and packing lunches for 7 days straight? It all adds up. And so I think it's like looking at information and data differently and normalizing that. So if I were to wish list this, I would say take the wellness data and have a wellness signal dashboard that you overlay against those OT spikes, that you overlay against those sick calls, that you overlay against your staff that's calling out or going on medical leaves of absences because they're tired, they're fatigued, they're burnt out. And so, sorry, but a quick story. 20 plus years ago, I had a nurse leader who did that without AI. She looked at me, she said, you're calling out a lot, sweetheart. And you've got a lot of talent, but if you keep this up, I'm gonna write you up. This is not okay. So what can we do? What's going on here? And she was the person who said, I'm going to put you in touch with a doctor and I need you to go get your labs run. It turned out I had chronic Epstein-Barr back then. And that changed the way that I approached my entire career from that point until I forgot about it again. And now I use a wearable to help me not forget. So it's important, these details.
I want to jump in on that if you don't mind, because I didn't have a chance, and I'm going to take it now. For the Clinician Burnout Foundation, I know the number one cause of burnout, or when you go to the American.
Ajay, you're muted, by the way.
Goodness, I'm muted. I apologize. What I wanted to say was to jump in on that, if I may, is
actually, let me go to Kim for a second. I think she wanted to follow on the response with Dana. Kim, okay.
Oh, that's fine. I'm fine waiting. I think it comes down to seeing people, right? People, humanity, for who we are. And that person, Dana, in your story that you just shared with us, that nurse saw you as a person, right? She cared enough to say, Dana, I'm concerned about you. She cared enough to have that conversation with you, right? That's key. That is, I think, the whole issue here, right? In our society, going back to that issue, right? This is a societal problem. We have to lean in. And by the way, there's data, there's research out there that supports that when we improve our emotional intelligence, which is translation into leadership, right? Development, what we do at Power Nursing, we improve patient outcomes. The money would take care of itself. It's all about taking care of people, right? And seeing people for who they truly are as our number one asset. This is what's going to separate us, because AI is here. It's here to stay. It's not going anywhere. We need to leverage it, and we need to look at how we are going to leverage human beings as they are in their strengths as people.
So I just wanted to jump in.
Beautifully said, Judy.
Clinician Burnout Foundation. So this is what I created this so that we support people on and off the job. If you're exhausted, take an Uber on us. Uber is a partner. We'll subsidize the ride. We will deliver food. We will do your laundry at home, like all these companies that provide childcare. So off the job, right? Because if you've worked and residents and anyone's like insane hazing, almost if you're working your third shift as a nurse, I don't want you to get behind the wheel. It's unsafe for you, anybody else on the road, but you can sleep. What if you have to go 45 minutes? But also there's clinical tech and AI tech and things that I'm working with Ajay, Ajay, I'm so sorry. But it's on and off the job, right? And it's lifting the bottom, because without that reserve, that's why we have so much attrition right now. Yes, it leads to errors, and absolutely, Kim, I completely agree with you. Better outcomes will lead to better profits, right? Because things won't close, more elective surgeries. Right. You're absolutely right. But I just wanted to mention with the Burnout Foundation, what I do is bring funds in, and we pay all of our for-profit partners or nonprofit partners so that they can give their services for free.
That's a brilliant idea.
The business model. This is not going to end burnout and moral injury, but if you don't lift the bottom, nurse suicide is now neck and neck with physician suicide and burnout. And so if we can't even lift the bottom, people are just going to keep quitting, and they're undereducated, 3-month, 4-month experienced nurses, but the nurse education is disappearing because they're underpaid and underappreciated. So, I just wanted to mention that I'm there giving things to clinicians to hopefully don't commit suicide, certainly, but hopefully will stay.
And we thank you for that. You're right. And you're right that there is a specific problem that we've got in terms of how we value our clinicians. I think we've said that a number of times, even though we know that clinicians are critical in delivering outcomes. Outcomes are why we're here. Outcomes are how we're compensated. So clinicians are how we're compensated. And Tanya, you mentioned that statistic that the companies on the Forbes 100 best places to work, those companies over a long period of time substantially outperform their peers financially by leaps and bounds. I think the statistic that Forbes came up with is that their stock valuations increased by 3.5 times their peers over 27 years. So it's a substantial size, a substantial sample size. And we as hospitals need to understand that, right? We need to take care of our people so they can take care of our patients, and both sides then. So there's a hospital revenue gain that could happen on both sides from the better clinicians and better outputs. That's what we need to help accomplish. So thank you, Tanya, for telling us about the program. Thank you, Jody, for agreeing to fund several pilots across the country through Clinician Burnout Foundation. I think we all agree that
I love you, Ajay.
That's what we just heard. Love Jody. But here's a question that I'd like everyone to answer, one at a time. And so this will be our exit question for the day. What is one misconception about nurse or clinician wellness that you would crush? Ram, let me start with you. What would you say?
Better take myself off mute. That's been a common mistake. Even through COVID, even though COVID existed, we still do that, right? We were all on Zoom, right? But what is one misconception? I think the misconception is that we're a superhuman. I think that's the major misconception, is that somehow everything that happens around us doesn't affect us. I still remember a young child coming in from like an elementary school whose airway collapsed in the emergency room, and it's been like 6-7 years, and it haunts me. The patient died. Right? So somehow, we're thought, oh, I just walked in there into the emergency room and I just walked out. Didn't affect me. So I think that's the big thing, that the trauma that some of the nurses here are speaking about, or whether I was exposed to what I just described, that somehow we just come out of that and nothing affects us. Nobody came to me to see how I was doing after that. There was no, and I'm not saying somebody should have, but I'm just saying that these are the kind of over and over again exposures that there's nothing, no one helps. There's no follow-up. You deal with it yourself. They're talking about day-to-day stuff. I'm talking about maybe one incident, but it's not the only, I'm sure I can enumerate. So I think that's the greatest misconception, that somehow that doesn't affect you. That happens all the time in terms of all the outcomes measures that we want to look at and so forth.
Thanks, Ram. Thanks for sharing. Kim?
Before I answer that, Ajay, I just want to say, Ram, I remember the first child that I had to put in a wagon and roll over across the hospital into the morgue. And I'll never forget that. And I talk to my students about that when I teach, to help prepare them, right? But to help them to understand our own frailty as humanity, and not to just stuff things, because that's not healthy. But my myth, Ajay, to answer your question, that I would love to see debunked, would be wellness is just about self-care. Like, the truth is, yeah, self-care is important. It's essential. In fact, it's a leadership quality, right? But it's not sufficient. Yoga isn't gonna help us get ourselves out of a toxic work environment. Nurse wellness is both personal and a leadership responsibility, and it starts with leading ourselves. But the truth of the matter is, and it goes back to my opening, is burnout is a systems issue. And solving it is going to require a radical culture shift, grounded in leadership development, improving psychological safety, and providing these structural supports, leveraging data in the process that's truly going to help people live into who they are, and show up for the patients that we have the honor and privilege of serving for. And that's addressing, those three facets of burnout. So, emotional exhaustion, depersonalization, and ultimately personal identity and how we show up. So cultivating that is essential, but it has to look at this through a lens of system change. Like, I'm looking at it from education and practice, and breaking down the barriers across the system of healthcare, and truly reshaping it from the inside out, right?
Cool.
Or the bottom up, however we want to say it.
Yep. Thanks, Kim. Dana, your thoughts?
Everything Kim just said, every single thing Kim just said, on stereo, on repeat. And I think I would just kind of further add on to that to say that this idea that clinician wellness is separated from quality or hospital quality and outcomes, and she just said it is all embedded in the way we practice and the way that we're able to continue this. So when nurses or any clinician feels exhausted or unsupported, safety events are going to increase. The communication is going to decrease. It's going to break down. There's going to be suffering there. And so you really just don't have as much of an opportunity to provide consistent, high reliability care. And I do think that we're finally at a space in time and technology where we have the resources to look at the unique individual clinician, but within the context of the system. And I think the misconception that resilience has become such a dirty word because we've weaponized it and we've made it about go do a yoga or do a 20-minute meditation. That's not okay. The experienced ROM, and I will push back, they should have checked on you. Like, that should be the standard normal. Like, we have standard work for certain things. That should be part of the protocol. Like, you're not going to fly a plane without de-icing the whole wing. There's certain things that we do not pass go. We do not collect $200 because to collect the $200, these things have to be embedded. And I do feel very strongly about that, if you can tell. And for once, there's power up. There's, what Jody's doing. There's the ability with intention to actually pull in these resources and embed them within our organizations, our large organizations, and put those data structures in place. And you can see it. You'll start to see what the effect is, because it is there. It is creating harm. It's creating harm to our clinicians. It's creating harm for our patients and their families. It's happening. So we can decide to stop ignoring it and putting our head in the sand like the ostrich, and I love ostriches, but that's not going to be the approach any further. We do need to shift this, and we have the resources to shift it. AI, to Kim's point, is not going anywhere. So we might as well use it in the most functional way possible to augment what we're doing.
Yeah, deliver. Jody?
I agree with what everybody's saying, and obviously all of us could say so much more. Starting with Ram, and then, of course, Kim was saying as well. So it starts with stigma, right? Clinicians are terrified they'll be fired or they'll be thought less of. And look, before COVID, everybody knows there's been burnout and suicide rates going back well before we had to move to electronic health records. Okay, it's documented many times over. But, the powers that be kept it hush hush. They were terrified of malpractice suits. COVID ripped the lid off of it. You couldn't hide it anymore. And that's a good thing, but stigma still prevails. And to what Ram was saying too, did anybody check in with you? If you're a police officer in the line of duty and there's a shooting, you are then required to be seen by a psychiatrist to make sure you're okay. If when you're in airlines, the industry requires a checklist before you take off, this, which reduces errors. And this is to your point, Ajay, which is other industries, frankly, do a lot of things better.
Better job.
Yeah, because healthcare is very plodding along. It's very slow to change. But I think I embrace AI. I embrace the data. I don't think it should replace certain people, but I think, yes, it can, to what Dana was saying, augment, certainly make things work better, workflows and processes. Make sure there is supply chain is fulfilled, so you're not reaching for something. And I've heard of this. Yeah. Well, I had this tale from a surgeon in a hospital in Maine. She was in the middle of the surgery. The patient was open. The chest was open. She needed a specific tool, an item, and no one in the operating room had it. They literally had to run because no one was answering in the sterilization area. The guy was on his phone watching an NBA game because there's such, it's just such a mess. And so it doesn't
not really acceptable, but
you have a prestigious job and it doesn't matter at this point. You know what I mean? It's like, because they're not paying enough. These people can make more money flipping burgers. That guy's sitting there. And it's everyone. And I agree. When you say system, it's, when the healthcare system is better, and it's the largest part of the GDP of the United States. Once that works better, everybody benefits.
It will work better.
Yeah.
Awesome. Tanya, let me give you that question. What's one misconception that you would strike? And I want to give you that question in a special way. I sort of came to you sort of last because you've got a defined program, right? So, and I love the fact that you said 3 months, that the hospitals will see a benefit in 3 months. So a lot of times clinical interventions take a longitudinal approach that you may see a benefit in 50 years, 20 years, long periods of time, right? Clinical interventions can take long periods of time. Obviously, they can take 1 and 2 years, but they can take a long time. We're not talking about 50 years. We're talking about Q1 to Q2. Can you talk to us about that? Right? What is it you see in this program that gives you confidence, which I share, that if we do clinical wellness, you're going to see a benefit right away?
Oh, I just absolutely adore you, Ajay, for where your heart is located and your mind is located. I just want to say this. Everybody with misconceptions and debunking, I need to say this first and foremost. I've been in healthcare 35 years. Since I was 10. I'm just kidding. What has really happened is burnout has not gotten worse. I don't believe it at all. I believe that burnout and the lack of and exhaustion has always been a part of healthcare. Look at Grey's Anatomy. They've been on 21 years and they've been all about exhaustion since the day that show started. I worked at the University of Pittsburgh Medical Center for 10 years, and that exhaustion was what made the community. And so here's what Power Up Nursing is filling. What is missing since COVID and since dying in solitude, and I say this with tears in my eyes, is a sense of joy and community in our hospitals. It is stripped away systematically, not just by COVID, but by for-profit interests, by pharmacology interests, by a lot of stuff that says, oh, you know what? Nurses can work at 3 different hospitals. We don't really need to have that community camaraderie. That is absolute BS. And what Power Up Nursing is seeing, and what even CFOs are responding is, we're going to have a little bit more joy around here. I'm going to hear a lot less complaints. I'm going to tell somebody, go look at your ring. There's going to be some fun jokes going around here. But more importantly, we're building a community that exists in one place that is generative, AI or no. It's creative, it's generative, it's technical, but it belongs to the nursing community to be proud of. And that's why I'm excited. Again, Ajay, I think why we're being successful, and I'm kind of shocked by it. Thank you very much, doctor. But why I'm shocked by it is this. There are people, doctors included, that I thought would be rolling their eyes left and right saying, I'd like to come to work where people make jokes again. And that's this is my last jewel in my career crown. And I want to go into some place and have people make jokes to me and to really feel like they are in love with the hospital they work at. Not just their patients. Nurses love their patients most of the time.
Yes.
They just don't love what is around them. And let's change that together. That's what I call power. It's the power of community, and it's the power of having fun. And that's where I would heal, in a hospital that has fun.
So well said.
So on that note, we're going to wrap up the show, but I just want to let everyone know a little story, about Ram. Yesterday or last night, his wife asked him if he could clear the kitchen table. He could. He just needed a running start. That's all. Come on, Tanya, that's your joke. That's your joke.
Give me a minute.
I want to thank all of you for joining us. Jody, Dana, Kim, Tanya, Ram, thank you for joining us and talking about this issue. This is a very serious issue. It's true. We mentioned the clinical workforce is at risk. And if we don't fix it, we're not going to be able to deliver these wonderful clinical interventions that we have. And we do think that there is an opportunity here to fix these solutions in the very near term. So even within the current fiscal year, a hospital can implement this program. Jody can help underwrite the costs through her efforts, and we can see a benefit right away before the end of that program, maybe even making this a net positive ROI in the very nearest term. Thank you again for joining us, and we will sign off another episode of the GOAI podcast.
Thank you.
Thank you so much.
Thank you.
Bye.